I know you're probably bored, and if you're living in some god awful place like the Northeast where it's snowing and cold, you're wondering, hey, how can I occupy my time and learn some infectious diseases? Well, lucky you, this is yet another Puscast covering the first 2 weeks of February 2015. References, of course, are over at edgydoc.com, where you can find links to my growing multimedia empire. And I command you, yes, command you, to go to iTunes and write me glowing reviews. And to plug myself twice over, the book The Puss Whisperer, honestly, that's the title, is now available on Amazon. And April 10th in New York, I will be part of a complete day of science-based medicine as part of Nexus, necss.org. Because, in truth, the world needs more Mark Crislip. But hey, you're not here to listen to me yammer. You're here to know about the infectious disease literature. Let's get started, shall we? The sapovirus and the norovirus are in the family of the calicivirus, which sounds very Game of Thrones, doesn't it? I wonder if the Dothrakis get infections from the calicivirus. Anyway, this study looked at the role of asymptomatic food handlers in outbreaks of caliciviruses in Denmark. And not infrequently, food handlers were asymptomatic while they were handling food and serving people, and then there were outbreaks of noro and sapovirus. It is of note that family members were often symptomatic when the vector was handling food, and of note, the vector did not always become sick with diarrhea from their infection. I've had one outbreak I think is associated with food handling in one of my hospitals. So it's important to remember that not only should the food handler not work if they're having diarrhea, but you should give consideration to limiting food handlers if their family members come down with the Hershey squirts. And if your food handler has been hired to serve at the Red Wedding, I think they have bigger things to worry about. I have yet to watch the Game of Thrones on HBO, although I'm dork enough to have read the entire series on Audible books. It's a wonderful way to read Game of Thrones. A couple of vaccination issues. One, we're doing pretty good, actually, in the United States for vaccinations. This looked at the seropositivity to the common childhood illnesses in the United States in 2009 to 2010, and seroprevalence across the country was pretty good. For measles, 92% are seropositive. For mumps, the seropositivity across the United States is 87.6%. For rubella, it's 95.3%. And for varicella, it's 97.8%. Unfortunately, the problem with measles is not so much the total vaccination rates across the country, is pockets of generally wealthy people where the vaccination rates have fallen well below those numbers to provide herd immunity. Also in vaccinations, it looks like the varicella vaccine is having some effect. This study looked at hospitalization rates for both zoster and chickenpox in Connecticut, and they found that they declined between 1994 and 2012, suggesting that the vaccine is having an impact on hospitalizations. If you've ever seen a necrotizing fasciitis from chickenpox or zoster, I've seen both, you'll appreciate that that's a good thing. And finally, for those of us who are hepatitis B vaccinated, I actually did not get a response. I'm some sort of mutant. But then you probably already knew that. I wish it was more like Wolverine. I would love to have adamantium come out of my wrists. Anyway, it looks like if you had the vaccine series, that your antibody levels stay high for up to 31 years, and that only 25% of cases will fall below protective levels, which rebound rapidly after a booster effect. So it would look like you have an excellent amnestic response to the vaccine as well. So those of you who actually responded to the hepatitis B vaccine, good on you. You're probably protected from hepatitis B, even if you don't have antibody at this point. If you're mutant, well, stay away from blood. And if a child in your household, an infant, gets the rotavirus vaccine, the parents and older siblings are also less likely to get diarrhea. So there's protection in the family by having the child immune to rotavirus. Let's move on to some HIV studies, shall we? New England Journal study looked at the results of HIV-positive patients receiving kidneys from HIV-positive patients and had very good outcomes overall. Rejection rates were 8% at 1 year and 22% at 3 years, and patients remained well controlled on their HIV. So it would appear that if you're HIV positive and you get an HIV positive kidney, that you do reasonably well in terms of getting a kidney transplant. The question always comes up about syphilis, and do you treat syphilis and HIV as you would other patients? As the article says, there is a paucity of studies to determine if treating HIV patients with the standard therapy is effective. The answer would be yes in this cohort study. Early treatment with a single dose of benzathine penicillin treats syphilis just fine in HIV patients. It is an important caveat in this study that the mean CD4 count was 494, pretty good, and that the lower the CD4 count, the less rapid the response to benzathine penicillin. So whether or not this applies to somebody whose CD4 counts are abysmal, like 50 or 100, is still uncertain. All treatment of infection is a balance between how good is the antibiotic, how virulent is the organism, and how good is the host response. But I think the take-home message is that one dose of benzathine should work, but of course the patient should get good follow-up. And sometimes abstracts are just kind of weird. This study looked at the utility of a bone marrow in patients with FUO and HIV and found that it was useful, and you got answers faster than more standard things like blood cultures. And they found typical and atypical mycobacteria, histo, and cryptococcus in these patients. So if you have an FUO and an HIV patient, a bone marrow might be the most expeditious way to reach a diagnosis. I think the funny part is the abstract, which says, quote, "To our knowledge, no such studies have been performed in Harris County, which has the highest incidence of HIV in the state of Texas," end of quote. My God, studies need to be done in Harris County. Just think of all the infectious disease studies that have not been done in Harris County. Pneumonia, meningitis, malaria. We need to do a malaria study in Harris County because, to my knowledge, no such studies have ever been performed. Harris County really needs more infectious disease studies. What a weird thing to put in an abstract. Now, I won't be giving grand rounds in Harris County anytime soon. And here's just kind of a cool article. It's in Retrovirology, the decline of human endogenous retroviruses, extinction, and survival. As you probably know, about 5% of the human genome is due to retroviruses that have incorporated themselves into our DNA and have stuck there. Interestingly, that is less common more recently. Using molecular techniques, they determined that most of the integration of retroviruses into the human genome was more than 10 million years ago, and that it has been less common over time, in part because of the, quote, recent extinction of one very large ERV lineage, which was responsible for most of the integrations over the past 30 million years. So while we have retroviral DNA chugging along in our genome, that's old DNA, and it's become less common in recent millennia. I wonder what the integration rates of retroviruses are in Harris County, Texas. I know, I need to stop it. We have these PCR-based respiratory panels that are increasingly showing large numbers of infections we hadn't diagnosed reliably before, and I've been seeing a ton of RSV this year. About a quarter of our influenza specimens are actually positive for RSV. There's a new strain of RSV, genotype Ontario, that was a problem in stem cell transplants in, my God, MD Anderson, Houston, Texas, Harris County. I'm in shock. Anyway, this particular RSV, the Ontario strain, was found in hemopoietic cell transplant recipients in Harris County. And as goes Harris County, goes the rest of the United States. It should be no surprise, but they found no link between the HPV vaccine and unsafe sexual behavior in teens. Or I should say, no increase in unsafe sexual behavior in teens who receive the HPV. Because to be a teen is to, if you can, participate in unsafe sexual behavior. And when they get the vaccine, and they do participate in the inevitable unsafe sexual behavior, they'll be protected from acquiring cancer-producing viruses. Seems pretty good to me. The headline at Medscape is latest Roche-sponsored Tamiflu review enters the fray. Warning, I'm a paid Medscape blogger. I'm their ID blogger. But I have to say that this is, again, more garbage that you see with Tamiflu. The current article on Tamiflu was sponsored by Roche, and it showed, consistent with the prior articles, that it decreases the length of disease by a modest amount, little less than a day, at the expense of more nausea and vomiting. They also found, in contradistinction to the article by the Cochrane Reviews, that they decreased hospitalization and complications. And the general gist that I have read on this particular review is that you cannot trust it because it was Roche-sponsored. And it's generally true that pharmaceutical company-sponsored meta-analyses have better outcomes than non-pharmaceutical company meta-analyses. But what all these things fail to recognize is what a pile of fetid dingo's kidneys the Cochrane Reviews are when it comes to influenza meta-analyses. And often the Cochrane Reviews in general, at least as it applies to areas that I'm interested in, i.e. infectious diseases, their vitamin C one was laughable, and alternative medicine, which is even more joke-ridden, though not intentionally. The main people for influenza on the Cochrane Reviews are virulently anti-treatment and vaccine, and their bias shows in what they do. So it's an interesting question as to which bias do you want to take. The biased bozos at the Cochrane Reviews, whose last article had some of the most ridiculous conclusions and ideas I have ever read in a paper, or the pharmaceutical shills. In this particular case, I'm going to go with the pharmaceutical shills. By the way, I've never accepted anything from Roche. If you're interested in more on this and like to listen, I would recommend Quackcast 42, the Tamiflu spin, Quackcast 109, One Flew Over the Cuckoo's Nest. That's Flu, F-L-U. It's a analysis of Dr. Jefferson's interview with Gary Null, one of the big-time alternative medicine proponents. And finally, Quackcast 42, the Tamiflu spin. These are also science-based medicine articles if you want to read them and look at the references, as well as Yes But, the annotated Atlantic. All these can be found in the reference section of the podcast, and I can rant for hours and hours and hours on what a crock the Cochrane Reviews are for influenza vaccine and treatment. I mean, Science Magazine quoted Peter Doshi about this study and called him an epidemiologist. He's an anthropologist who has signed a petition at one time suggesting that HIV was not the cause of AIDS, just the kind of person you want doing your meta-analyses on the treatment of viral infections. Jesus, give me a break. I do not know why the Cochrane Reviews has such cachet in some areas, because whenever I read them carefully, so often they're crap. Two interesting studies on Bartonella. One out of Brazil looked at the incidence of Bartonella species in blood donors and found Hensley in 1.2% of patients, suggesting that Bartonella can be spread as part of blood transfusions. And you may say to yourself, hey, I live in Harris County, not Brazil. How does this apply to me? Well, there have been studies to show that people that get cat scratches and cat bites will frequently have Bartonella in their blood, sometimes asymptomatic. How often does this occur in veterinarians and veterinarian technicians who are frequently exposed to cat, aka the other white meat? They found Bartonella in 28% of veterinary workers, most of whom were asymptomatic except for headache and irritability, which I would be too if I had to deal with cats for a living. But it would be an interesting study to see how often in the United States, like say in Harris County, Bartonella is found in transfused blood. Many people have cats and dogs, much less being veterinary workers, and perhaps it's a more common cause of fevers than we suspect in blood transfusion patients. But enough of that. Let's head on to gonorrhea, shall we? This study looked at the persistence of DNA following treatment of rectal and pharyngeal gonorrhea and found that a significant percentage of patients had persisting positive DNA 14 days after therapy. It was 8% of men in this study. What does that mean? Well, in some patients, it represented reacquisition of gonorrhea. In another group of patients, it represented the fact that the gonorrhea had higher MICs to both ceftriaxone and azithromycin, although whether or not this was associated with transmission is uncertain. But if you do test of cure for gonorrhea and you find that there's still DNA there, it may be reinfection, or it may be that you have a harder to kill gonococcus in your midst. One of the things I always whine about, and whine I do, is we put all this effort on MRSA, but actually it's staph in general that's the bad thing. This study looked at dialysis patients who were colonized with staph. They found that half at any given time had staph aureus on a swab. 10% were MRSA. But if they were not successfully decolonized from their staph, they were markedly more likely to have staph bacteremia and death compared to those who were successfully decolonized. Staph aureus is a bad player. I often say that if I were a superhero, Staph aureus would be my arch nemesis. And where are they going to get that Staph aureus from? Well, generally speaking, it's thought it's the community. But this curious study out of Australia looked at the risk of acquiring Staph aureus if you were in the room of somebody else who previously had MRSA, and the unadjusted odds ratio of you acquiring MRSA if you were in a room with a prior MRSA patient was 2.9. Emphasizes the importance of making sure your rooms are well scrubbed at discharge, especially in patients who have MRSA. I don't know, sometimes I wonder. This study looked at who needs a TEE with enterococcal bacteremia, and they came up with a score, a NOVA score, N-O-V-A. N is for number of positive blood cultures. O is for origin of bacteremia. V is previous valve disease. And the A is auscultation of a murmur. Each gets a score. And if it's greater than or equal to 4, you're likely to have endocarditis. On the other hand, the big two in this particular are having a sustained bacteremia and having bacteremia without an obvious source. That somewhat defines endocarditis, doesn't it? What they've done is quantified clinical acumen to help determine who has endocarditis. So if I had a 1 out of 4 with urosepsis in a patient who had no underlying valve disease, I wouldn't worry about endocarditis, NOVA score or not. If I had 3 out of 3 positive blood cultures and a prosthetic valve in a patient with no source of origin, I'd fret a bit. I don't think this is a useful study. I mention it because it will probably pop up now and then, but I usually find most of these scores to be not as useful as one would like. Plus, it was a study out of Madrid, Spain, not Harris County, so it needs to be repeated anyway. And this study out of University of Oklahoma is really sad, but not surprising. They looked at the use of antibiotic selection for uncomplicated urinary tract infections and looked to see how often people followed the IDSA guidelines. 33.96% of the time. Let's say 34. Give them a 0.04% benefit of the doubt. I am not surprised. Years ago, we did a similar in-house study at one of my hospitals and found that most of the time people were not following guidelines for the treatment of uncomplicated urinary tract infections. as I remember it, and it was like 15 years ago, that every patient who had a UTI had a slightly different prescription of antibiotics given. And you would think in this day and age, if there's anything that we know how to treat, it's an uncomplicated UTI. I mean, that's just so sad and typical. Why do people fail in their urinary tract infections? Well, the recent study out of Turkey suggested that there's a new clone of E. coli, the ST131, that has an increased risk of failure of therapy, 3 times that of other strains. All E. coli are not the same, all bacteria are not the same, and this certainly appears to be the case in the treatment of urinary tract infections. As I remember in my reading of the literature, yogurt is probably better for preventing antibiotic-associated diarrhea than probiotics, especially given all the issues surrounding supplements. This study was in kids, and kids were randomized to receive yogurt containing Lactobacillus bifidobacterium and Lactobacillus acidophilus versus pasteurized yogurt. Poor kids, either way, they had to eat yogurt. And those that got the yogurt with bacteria in it were less likely to have antibiotic-associated diarrhea. Somebody, I still think, needs to do this study with Hefeweizens, although probably not in children. But given the sketchy nature of supplements, I'm sure you saw the recent study out of New York where roughly 80% of supplements did not have in them what was on the label. In fact, they often had nothing. That you really can't trust supplements, including probiotics. And so my reading of the literature and preference would be go with the yogurts if people can tolerate it to try and prevent antibiotic-associated diarrhea. The future, however, is probably going to be in stool pills. Certainly that will be nice for treating C. diff, and I assume that there'll be studies done to look if stool tablets, fake poo, is beneficial in the prevention of antibiotic-associated diarrhea. The downside, there is a case report of a patient who received a stool transplant because of C. difficile, who received her stool from a healthy but overweight donor, and the patient subsequently went on to gain weight. Certainly there's been this interesting, predominantly mice studies to show that the fecal flora determines whether or not you're a fat mouse or a skinny mouse. And this case report suggests that you can transplant obesity along with the stool. I don't know if I buy it, but at their institution, they now no longer take fecal flora from overweight people, but only thin people for their stool transplants. You know, I'm getting shorter and shorter on these discussions as time goes by, but so often, really, there's just one take-home message from sometimes long and tedious papers. 1, low platelets is associated with increased mortality with malaria. 2, a PET scan is a great way to work up a vascular graft infection. But generally speaking, the literature for using PET scans in infectious diseases for things like FUO and now graft infections and other infections is great. I wish it wasn't so damn expensive. It's like $8,000 in the United States, and most insurance companies will only pay for a PET scan if the patient is suspected to have malignancy. Still, PET scans are underutilized in ID probably because of cost reasons. And 3, an elevated adenine deaminase in pleural fluid is diagnostic for tuberculosis, or at least highly suspicious for tuberculosis, even in a population where tuberculosis is uncommon, in this case being Scotland, not Harris County. And finally, antibiotic-caused deaths. There have been several studies out of the United States demonstrating that macrolides, specifically azithromycin, and quinolones are associated with an increased death rate. This was again looked at in Taiwan and looked at the death rates in patients who were put on macrolides, quinolones, and beta-lactams, and found that quinolones and azithromycin were associated with increased risk of death. Of the quinolones, moxifloxacin was the worst of breed. So ventricular arrhythmias are a well-established now risk from those agents. If you're interested in odds ratios, for azithro it was 2.62, for moxie it was 2.31, and for levofloxacin it was 1.77. Some studies have suggested it's people with underlying cardiac arrhythmias that are at most risk for having this issue, but given drug-drug interactions, there's always the worry that you may incite death by giving these agents. For example, there's a recent study also that showed that if you are put on TMP sulfa and spironolactone, it doubles your risk of sudden death. So there's more to death than just the arrhythmias of quinolones and macrolides. Bactrim, which is an evil drug that I try to avoid, it's not really evil. There's so many complications and side effects compared to other agents. It's a sign of my upbringing. I tend to be a beta-lactam kind of guy. So I think that brings us to an end. Don't forget to go to Harris County, Texas, HARRISCOUNTYTX.gov to find out more about the wonder that is Harris County. And also go to edgydoc.com to find links to the references and links to my growing multimedia empire. Otherwise, of course, you are to go on iTunes and write me glowing reviews. And as I said at the beginning, don't forget the Pus Whisperer is now available on Amazon. An edited version of my first year's blog entries at Rubor, Dolor, Kalor, Tumor before I went to Medscape. So these essays exist nowhere else except in my delusional memory. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you, in dictation, and goodbye to Harris County. Let's wander on over to the Wikipedia. What do we got here? Harris County, 4.1 million people. Wow. Looks like poverty is a problem. 20% live in poverty. 6.5 per thousand die before age 1, 38% dropout rate. They are employed by Administaff, Compact, Continental Airlines, University of Houston is there. They got some major highways. Wow. Police and fire are there too. Pretty exciting. And they have emergency medical services. Bunch of cities. Wow, a lot of cities live there. Seabrook and Pasadena and Hedwig Village. The Angry Hedwig Village. It's a small village, only half an inch. They got the George Bush Intercontinental Ballistic Missile Airport and a hobby airport. Oh, William P. Hobby. I thought it was just an airport they did for fun. Lots of big buildings. Not bad. I think I'll continue to live in Clackamas County in Happy Valley, Oregon. Wait, is this recording? I don't think so.